1 disc diameter in size. Grade 3 were described as more than 1 disc diameter in size but not involving the foveal center, whereas grade 4 tears were greater than 1 disc diameter and fovea involving, and obviously with the worst visual prognosis. Several risk factors have been identified for development of RPE tears in patients with pigment epithelial detachments. Increased surface area and a PED height of greater than 400 micron has been associated with increased risk of RPE tear. Interestingly, a small ratio of CNVM size to PED size has been associated with the risk of tear. Similarly, other risk factors are presence of radial hyperreflective lines on near-infrared reflectance images, a short duration of PED less than 4.5 months, and presence of micro rips seen on fluorescein angiogram. One study prospectively looked at incidence and risk factors for the development of RPE tears after high and low dose ranibizumab. Patients were divided to receive either conventional 0.5 milligram dose of ranibizumab or much higher dose of 2 milligram, and they were followed for 12 months time period. This study showed that increased PED height, greater linear diameter, and presence of large surface area was associated with increased risk of RPE tears. Similarly, a presence of a ring sign, which is a ring of hyperfluorescence at the outer margin of the PED, was also statistically associated with risk of development of tear. Overall rate of RPE tears in this study was about 14%, and out of 5 tears, 4 were in the high dose group of 2 milligram. This may be by chance or may be truly associated with higher dose, but since the sample size was relatively small, so it was hard to predict for sure. The study also demonstrated that PED height of greater than 550 micron increased this risk from 14% to 31%, and if it was a high PED and there was also a ring sign present, then the risk of RPE tears was 67%. So some have advocated a reduced dose for high-risk PED. This is a single case report. This patient has pretty sizable PED and has relatively good vision. So rather than full dose and at monthly interval, this patient received 4 bi-weekly injections of 0.25 milligram ranibizumab. And after these 4 injections, the PED has flattened reasonably well and the vision was maintained. The authors suggested that possible slow and controlled contraction of CNVM with potentially reduced stress on PED may help prevent an RPE rip. We'll look at a couple of cases of RPE tear development and try to identify some of the high-risk features we have discussed. This is a patient with large PED and subretinal fluid, and you can see there is a subretinal fluid and large PED. The patient was given an anti-VEGF injection and comes back 5 weeks later, and you can see there is presence of this wrinkling on this OCT, and on near infrared reflectance images there are, I don't know how well it is projected, but there are some radial lines here. Another injection of anti-VEGF was given, and the patient starts developing a frank RPE tear. This is a fundus autofluorescent picture showing absence of RP in this area of hypoautofluorescence and an RP tear. Further treatment with another injection led to further increase in the size of the RP tear, reaching almost to the edge of the fovea. Another case of RPE tear with subretinal hemorrhage. Patient came with reasonably good vision of 20/30, had PED with a small amount of subretinal hemorrhage here. Patient was given 4 injections over 21-week time period, and then unfortunately developed a large RPE tear, vision reduced to 2200, and subretinal hemorrhage is much more massive, and you can see area of missing RPE in the superior macula here. So a question comes, is more potent anti-VEGF agents, do they increase the risk of RPE tears? There have been recent case reports of RPE tears with faricimab treatment, which is a dual mechanism of action. In US Tenaya and Lucerne studies, which were phase 3 neovascular AMD studies comparing faricimab with aflibercept in terms of safety, efficacy, and durability, there were numerically higher number of RP tears in faricimab group compared to aflibercept. In Tenaya trial, there were 9 RPE tears in faricimab group versus 7 tears in aflibercept group. In Lucerne trial, there were 10 RPE tears in faricimab group compared to 3 tears in aflibercept group. So what should be the optimal management of RPE tears? First step is to identify high-risk PED at the onset or during the anti-VEGF treatment based on these features. If you identify any of these features, frank discussion with the patient should be done regarding the risk of RPE tear formation in the presence of these high-risk features, as well as risk of potential progression of early grade tears into the higher grade tears with or even without the treatment. Small tears can generally show slow improvement in the vision with continued treatment, so the treatment should not be stopped. Possible suspension of therapy can be considered for features suggesting imminent development of RP tears such as RP wrinkling on OCT or radial lines seen on near-infrared reflectance images. Anti-VEGF treatment should not be stopped in most patients with RP tear and active disease, as indicated by presence of intraretinal or subretinal fluid. So far, no clear evidence of different risk based on the dose or type of anti-VEGF agent has been identified. Back to our patient who developed an RP tear, she continued to have treatments over next 18 months time period and developed a subretinal scar, but is maintaining a 20/80 vision with a continued treatment. Thank you very much for your time and attention.
We do that, we measure the height, and if it's more than 400 microns, then my practice is not to start them on faricimab, I start them on aflibercept, because we look at Tenaya and Lucerne, the RPE RIP rate was 4.4% with faricimab and just about 2% with aflibercept. And that's the Royal College recommendation as well. Secondly, I was a bit surprised in your case because we know that large serous PEDs definitely have a high risk, but hemorrhagic and fibrovascular ones less so. But your case looked like a fibrovascular one because it wasn't like homogeneously dark under the PED and it ripped. So probably to do with the tangential the tensile strength of the retina and the way it shrinks. We carry on treating despite an RPE tear because there's no other alternative. The only time we stop is when the rip is through the center of the fovea and the vision drops to 696, which is about counting fingers 3 meters.
Okay.
But yeah, excellent talk.
Thank you. Yeah, basically, more important in settings of Pakistan, you are going to treat somebody with 100,000+ rupees of injection, and if they come 1 month later, nobody's going to be happy. So, patients do understand, and they are sometimes, obviously, if you tell them in advance, it's much more like an easier life for you and patient understanding as well. But, just like there was actually a physician here, an orthopedic surgeon whose wife actually had a large PED, and I told them that I'll treat them once. It was okay. Then in my absence, somebody else treated them in an RP. Fortunately, there was a discussion before. Otherwise, it would have been much difficult to.
Just to clarify, that ring sign that you said was in fluorescein angiogram?
It has to be on a fluorescein.
And those tiny folds, that
can be on OCT or near infrared reflectance images.
If we have these tears, so what is the end result of this patient? Is affecting the vision gain, or there is a way of management, or just we are looking to find it?
And that was the last slide. Basically, generally speaking, you will continue treating because, you don't have anything else. But if, as Dr. Shafkat has told us, that it's just if the center is already gone through the center RP and like a grade 4 tear, there's not much you can do. So at that stage you will stop. But even this patient, if you don't do anything, my patient had 2100 vision, but 18 months, even if there is a scar, some vision maintenance there, natural history would not have been like this more than likely. So you continue treating and very rarely you would stop. Only they say that if you can give a pause to the treatment, if you see wrinkling on the OCT, like after first injection, you probably may give a little pause to see what happens, and maybe there's more slow controlled sort of a closure of the like those neovascularization, and maybe there is a chance that there will be, because as he's saying that there is if fibrovascular PEDs are less likely to cause tear because there is some protection by that fibrotic tissue. So if you let fibrosis form, maybe that will protect against a frank RP rip.
What times?
You're right.
Down too rapidly, so it flash times and.
You're right. It's a protection from like a rip.
So our aim is prevention rather than treatment.
I'm sorry, prevention?
The aim of we have to see if there is a risk factor and to take care not to reach to have this complication.
That's why you identify with the high-risk features. Remember that all these studies, the big studies of AMD, they exclude these patients from the study. So the true volume is not known. These patients in these faricimab trials, they were not high-risk PEDs. If a patient is a high-risk PED, most of these patients are actually not included in these large controlled trials. So the volume of problem may be higher than what is seen in these studies.
Sorry, Dr. Bilal, we're running short of
Okay.
time.
Thank you.
you.
And then,
So if I could have the next presenter, Mr. Shafkat, if you would be so kind.
Thank you very much. So I'm going to talk about dry age-related macular degeneration, more about dry AMD and less about management, because the management is not approved in UK. We'll get some feedback from Bilal about dry AMD treatments, because it's more than a year that US has been using them. So geographic atrophy is a significant cause of blindness in the UK and in Europe. Globally, AMD is the leading cause of blindness in adults above the age of 50. Dry AMD comprises majority of AMD cases because AMD, advanced AMD, contains both dry and wet AMD. GA is a progressive advanced form of dry macular degeneration and is characterized by the loss of retinal cells directly responsible for visual function like RPE photoreceptors. Prevalence of late AMD is estimated to be rising, open 5% in the general British population, with up to 4.3% of those above the age of 75 having GA. The prevalence, if you look at that, early AMD and intermediate AMD is about 25.3% in Europeans above the age of 60. Late AMD, including both neovascular AMD and GA, is 2.4%. And this is based on meta-analysis of published epidemiological surveys. So, what is normal retina? So we see drusen's very frequently in the Western Hemisphere. So normal retina has no drusens or drusens less than 63 microns in size with no pigmentary abnormalities. Early AMD is classified as medium-sized drusens between the size of 63 and 125 microns and no pigmentary abnormalities. And by the way, we don't actually use a caliper to measure the size of drusens. We just compare it to the size of the vein as it comes out of the optic disc, because those major veins have around 117 to 125 micron diameter. Intermediate AMD is large drusens greater than 125 microns and or pigmentary abnormalities, both hypo or hyperpigmentation. And then late AMD can be neovascular or GA. So progression of GA is due to drusen accumulation in retinal pigment epithelium. You can see on the left side, the cartoon demonstrates normal retina with normal layers. Please note the presence of RPE, the basement membrane, and choriocapillaris. And as we move into early and intermediate AMD, it's noticeable that the Bruch's membrane thickens and there is accumulation of drusens, and drusens are present under the RPE. Also, there's infestation of the outer retina with microglia and activated phagocytic macrophages. This thickening of the basement membrane occurs from accumulation of toxic products, byproducts, digested external membranes, phospholipids, that causes the thickening of RPE. And then the onset of geographic atrophy is associated with accumulation of large-sized drusens, thinning of basement membrane, and RPE atrophy. And please note the presence of these guys here, reticular pseudodrusen, and we'll come back to that in a minute. So GA, different types of GA lesions, they progress differently, and again, this is from epidemiological studies. GA lesion with a progression rate of 1 square millimeter per year is seen when you have a single solitary lesion. These are all fundus autofluorescence images, and that's the best modality to examine early GA alongside OCT. And so these lesions, central lesions with minimal changes around them, they progress at a rate of 1 millimeter square per year. The B variety is the lesion which progresses more rapidly. These are 2 millimeters square per year, and they have widespread changes. They're multilobular, multifocal, and they have a lot of these fundus autofluorescent changes, hyperfluorescent changes around them. And then the third type is the really rapidly progressive one, which is 5 square millimeters per year. And this is the one which contains these reticular pseudodrusens. So multilobular, usually center sparing, and having a reticular pseudodrusen around them. The etiology of GA is obviously a complex interplay between environmental factors and genetic factors. Genetic factors are much more important, but equally we can modify the disease when we see the patients and diagnose them with a dry AMD. We do give them a leaflet that contains all these risk factors. Obviously, age is the most important one because it's not seen under the age of 55. But then smoking, a diet, high in processed food, high alcohol intake, high body mass index or metabolic syndrome, and comorbidities like hypertension, coronary artery disease, peripheral vascular disease, carotid stenosis, hyperlipidemia, chronic kidney disease, diabetes and sleep apnea, Alzheimer's. All these are associated with dry AMD. But as I said earlier, genetic factors are much more important, and it's the presence of these genes that produce changes in the complement level and produce abnormal changes in the complement cascade, like complement factor H, C3, and the ARMS2 gene. They are associated with much heightened risk of having advanced or progressive geographic atrophy. And they also produce, the same changes as there is alongside drusen formation, oxidative phosphorylation of cellular membranes, and increased immune response, giving rise to inflammation in the outer retinal layers. So this dysregulation of the complement system, which is characteristic in geographic atrophy, is the role is played by genetics, as we've said earlier, complement factor I, complement factor H, which normally inactivate the complement pathways in healthy host cells, but in these patients, there's dysregulation of the alternate and the classical pathway of complement cascade. Histologically, complement proteins have been detected in eyes with GA, including in drusen and peripheral atrophic lesions as well. And both the presence of GA-linked genetic variants and complement activation in the retina causes photoreceptor death, and this has been found in preclinical studies in animals. In GA, loss of appropriate regulation of the complement system causes destruction of otherwise healthy retinal cells. So when we look at the complement system, the activation is as a result of environmental factors, age, and then genetic predisposition. and complement factor H, C3, CF, CFL, all these contribute. And this sets up a chain reaction. There is accumulation of extracellular debris, there's RPE damage, add on to that the oxidative stress caused by superoxide and nascent oxygen molecules, and all this sets up an inflammatory response. This inflammation goes on multiplying, escalating, and leads to accumulation of toxic products in outer retina. So this leads to drusen formation, and drusens, they give rise to or lead to breakdown in outer blood retinal barrier. The complement components and pro-inflammatory molecules, they're recruited in a sort of a chain reaction, and this leads to hyperpigmentation, RPE atrophy, and photoreceptor damage. We've already discussed this, but not only does all this cascade and inflammation and accumulation of toxic products in the outer retina and RPE lead to atrophy, but they also then go on to produce damage and wet macular degeneration, because those important barriers in the outer retina are broken, and we're going to just have a quick look at them. So what do you look for in patients where you suspect that there is dry macular degeneration, or what are the prognostic factors that tell you that this is going to be a more progressive case, which will rapidly progress? So you look for reticular pseudodrusen, also called subretinal drusenoid deposits. You look for subsidence or sinking of the inner nuclear layer outer plexiform junction. You look for loss of RPE in photoreceptor layers, external limiting membrane loss, loss of ellipsoid zone, and presence of hyperreflective foci. And I'll also touch upon on degenerative intraretinal fluid, which is different from neovascular fluid. So reticular pseudodrusen, they're called pseudodrusen because they're present above the RPE. So normally, the classic description of RPE of drusen is that they are sub-RPE, but reticular pseudodrusen are above the RPE. Secondly, they tend to have this triangular shape, and they tend to pierce through the external limiting membrane like a little pyramid with a cone going through the external limiting membrane. And they are present, if you find these in majority in the retina, particularly surrounding the areas of definite geographic atrophy or retinal thinning, then that's going to be your progressive case. Subsidence is sinking of inner nuclear layer, outer plexiform layer. So you can see this subsidence with a little hyperreflective wedge.
Sorry, Mr. Shafkat, we are over the time limit.
Okay. Hyperreflective foci, like wet AMD, are a sign of activation. And so I want the trainees and fellows to understand the concept of incomplete and complete RPE and outer retinal atrophy. So this is the terminology that we use in describing dry AMD, iRORA and CRORA. With CRORA, you can see hypertransmission defects like broad hypertransmission defects, complete loss of ellipsoid zone, complete loss of external limiting membrane, and sometimes you see degenerative fluid, little clefts which are not VEGF driven. So even if you give them 10 injections of AntiVEGF, those will still be there. Just a quick word. So the two agents that are licensed for dry AMD, these are intravitreal injections given 1 monthly or 2 monthly in the studies, are Syfovre or pegcetacoplan, which is a C3 inhibitor, and Izervay, which is avacincaptad-pegol, which is a C5 inhibitor. And both of them, they reduce cell lysis by inhibiting this complex, this killer complex that breaks down the cells. Syfovre, it works slightly upstream compared to Izervay, and they reduce the progression of, so this is the last slide. Complement inhibition leads to slowing down of dry AMD by 14 to 20%, depending on which agent. Syfovre, which works slightly upstream, is associated with 20% slowing down, whereas Izervay, which is a C5 inhibitor, with 14% slowdown of increase in GA. They do not improve vision, and the patients do not regain lost vision. There are risks associated with both, including activation of wet AMD on the edges of GA, intraocular inflammation, including occlusive retinal vasculitis, and raised IOP. And although we said Syfovre is slightly better at reducing the rate, it's also associated with slightly higher complication rate compared to Izervay. The new kid on the block is photobiomodulation. The LightSight 3 trial showed that stimulating the RPE layers by 3 different wavelengths ranging from yellow to near infrared in 5-minute cycles, 9 sessions per week by a light delivery system. And in the UK, it is actually approved not in the National Health Service, but privately, given through the Valida light delivery system. In early and intermediate dry AMD cases, with people vision of 636 or better, we don't use it in patients who have 660 or less vision. It does actually increase the visual acuity by 5 letters, or roughly 1 line, in 55% of the patients. And none of those cases progress to GA. But a larger trial, EuroLight trial, with about 1,000 patients is now underway, and the report should be coming in about a year's time. LightSight was a small sample, it was a 100-patient trial. And that's it, I think. Oh yeah, just some take-home points for fellows and trainees. Please try to identify reticular pseudodrusen. They're present above the RPE. They have a triangular shape. They penetrate through external limiting membrane. Differentiate between degenerative fluid and neovascular fluid. You don't have to treat degenerative fluid. Try to make a diagnosis of complete RPE in outer retinal atrophy, C-RORA, which is basically, end of the line for those retinal cells. And, just to let you know about Syfovre, which is a C3 inhibitor, Izervay, which is a C5 inhibitor, and photobiomodulation. Thank you.
Thank you, Mr. Shafkat. Because we're running a little late, we'll field questions at the end. Okay. You also have a second presentation.
I think I have.
Would you like to continue or take a break?
So, post hoc real world data, and this is the US cohort of faricimab. This is the FAR Retina study. So it's an ongoing retrospective study using electronic health record data, which is supplied by use ophthalmology clinics to the American Academy of Ophthalmology's IRIS registry, which is Intelligent Research Insight Registry. And the objective was to describe the 2-year real-world clinical and anatomical outcomes of faricimab treatment in patients with neovascular AMD. I'm going to present neovascular as well as DMO findings here. So data was analyzed from patients' eyes with neovascular AMD who initiated faricimab between February 22 and September 2024 and had 12 or more months of medical data prior to faricimab start, 24 months or more of follow-up medical data after faricimab start, and 2 or more visual acuity measurements on or after the first faricimab injection. A subgroup with central subfield thickness data included patients with a baseline central subfield thickness of a measurement 0 to 30 days prior to faricimab initiation, and 2 CST measurements in the 6 months before, and 2 CST measurements in the 6 months after faricimab initiation. So the total number of patients having injections during this period were 267,852 eyes. The 24-month cohort was completed by 6,799 eyes. Mean age of the patients was 80 years. Majority were women, as most epidemiological studies show. And out of these, 6% were treatment naive. They hadn't had any injections before, whereas 94% were high flyers. They were patients who had been treated before, and the vast majority had been treated with aflibercept, 2 milligrams. So we look at the median visual acuity at baseline and 4 months, and 24 months after starting faricimab. There was no loss of vision. 51.2% had 20/40 visual acuity at baseline. And we look at the previously treated, the treatment experienced group, again, no loss of vision, 70 and 70 letters after 24 months. So prior studies have shown a decline in visual acuity, after the first 2 years. Obviously, this is an ongoing study, so we will be reporting on 3, 4, and 5-year data at a later stage. However, vision is maintained after 24 months of treatment with faricimab in both naive and experienced eyes. Subfield thickness, if we look at treatment, naive eyes baseline was 299 and after 24 months 256.8 microns. In the naive eyes, 291 in the previously treated eyes, going down to 259. So in both groups of patients, faricimab was able to reduce central subfield thickness. Lower CST at baseline versus faricimab treated patients was seen in the Tenaya and Lucerne clinical trials, who had a mean standard deviation baseline CST of 356.8. So in this trial, and if you start off with a lower point, it's even more difficult to reduce central foveal thickness. So these patients did well, and faricimab was actually able to reduce the central foveal thickness more. If we look at faricimab injections, and that's what it's sold on, that it's non-inferior to aflibercept, but it is a more durable compound. It gives rise to more longevity, and you can keep the macula drier for a longer period of time. If you look at that aspect, then in the treatment naive eyes, in the first 6 months, they received 4.2 injections, and that's what we do in UK as well. We start off with a loading dose of 4 injections. Everybody gets a 5th injection 2 months after the 4th, and then depending on baseline, post 4th and post 5th, looking at the vision, CFT, and other features, then we decide whether we're going to extend by 2 months, 3 months, or 4 months to a maximum of 4 months extension in year 1. So looking at this, in the first 6 months, they had 4.2 injections. And then if you look at the next 3 6-monthly slabs, the number of injections has gone down. In the previously treated eyes, 4.4 injections in the first 6 months, and then going down in the next 3 slabs. But obviously, more frequent injections, because these were resistant patients, an aggressive phenotype, as we all know. So mean number of faricimab injections in Tenaya and Lucerne was 7 in year 1, which is very similar to the real world. If you look at the first 2 years, the first year, and 4 in year 2. So, very similar as we see here, weeks 60 to 108. So in conclusion, for retina, neovascular AMD is the largest real-world study of faricimab for treatment of neovascular AMD. After 2 years of faricimab, visual acuity was maintained in treatment-naive and previously treated eyes. CST reduction was also observed. Number of injections reduced after fixed 6 months, suggesting extension of treatment intervals in year 1, which continued through year 2. And safety data was evaluated, and I'm going to talk about this towards the end. So now we're going to talk about the DMO. Our eyes, 953 patients. Mean age was 69, much lower than the AMD group. 46% were women, so men were more affected in DMO rather than AMD. 157 treatment naive eyes, and 1,097 or 87% previously treated eyes, and 73.1% switched from aflibercept. If you look at the median visual acuity, 65 letters going up to 70 letters after 2 years, so 5-letter gain or 1-line gain. And if you look at previously treated eyes, no change, so stabilization of vision, but at a lower injection frequency and lower burden to the patient and to the society. If we look at a mean central subfield thickness, it's come down from 367 to 301 in year 2, and lower CST at baseline versus patients in the treat and extend arm in the Yosemite and Rhine clinical trials, who had mean CST of 478 at baseline. So again, they started off with lower baseline in the real world data compared to the landmark trials. Injection frequency, first 6 months in the treatment-naive eyes, 4 injections, and coming down successively in the next 3 6-monthly slabs. Previously treated eyes, 4.1 in the first 6 months, and then progressively less injections, but obviously more than the treatment-naive eyes. And mean number of faricimab injections in Yosemite and Rhine was 9 in year 1 and 4 in year 2. So pretty accurately reflecting what was seen in landmark trials and in that was seen in the real world data as well, which is a bit unusual. Now let's look at the rates of inflammation and endophthalmitis. This is pooled safety data across neovascular AMD and DME. So percentage of eyes, treatment-naive eyes with intraocular inflammation, 0.3%, and in previously treated eyes, 0.2%. Endophthalmitis rates in treatment-naive eyes, 0.3%, and 0.1 in previously treated eyes. So this is pooled adverse events across AMD, DME, RVO in both far retina and far wide. That's why there are such high numbers. So this gives you an idea about the safety of the drug. In 17,913 eyes, or 115,320 injections, 0.15 intraocular inflammation rate. In treatment-naive eyes, very similar. In previously treated eyes, and in if you look at the endophthalmitis rates, very similar again. So in conclusion, far retina DME is the largest real-world study of faricimab for treating diabetic macular edema. After 2 years of faricimab, visual acuity improved in treatment-naive eyes and was maintained in the previously treated eyes. There was no reduction in CST in previously treated eyes. Number of faricimab injections reduced after the first 6 months, suggesting extension of treatment intervals in year 1, which continued through year 2. And the safety data evaluated were consistent with the phase 3 Yosemite and Rhine and Tenai and Lucerne trials. Thank you. I'll take any questions now on the 2 talks if that's okay.
I think it's fine. Any questions from the audience?
Doctor, do you have any comparison between the 8 milligram now Eylea and faricimab?
I personally haven't started 8 milligram. It's a bit of a political issue because in 1 month's time we're going to have Yesafili, which is the first aflibercept biosimilar, and my pharmacy is not keen to get me on 8 milligram because if I start using it, they can't ask me to stop that and switch to Yesafili. But there are units in UK who have been using it for about 3 months, so it's too early to see. We haven't had any audits or anything like that. I just want to ask the trainees and fellows and registrars, you okay with the description of C-RORA, I-RORA, and pseudodrusins and degenerative intraretinal fluid? That's the important thing, key message to take.
Assalamu alaikum. Any role of anti-VEGF on the geographic atrophy? On GA?
Only if they develop secondary choroidal neovascular membrane, and there have been instances of both Izervay and Syfovre patients developing CNV in those cases, but no, otherwise not.
But aflibercept is saying that it is decreasing the geographic atrophy.
So again,
Aflibercept has an effect on reducing the size of geographic atrophy. They are reporting in.
So if
Not on the scene.
aflibercept has dual function, it's anti-VEGF and it's a platelet-derived growth factor inhibitor. So if the second cytokine, if that is important in geographic atrophy or certain cases of geographic atrophy, then yes, it may have an effect. But we're not allowed to use aflibercept in GX.
In comparison with complement inhibitors and this aflibercept, is there any study? Do you have any idea about
No, I'm not aware. Bilal, have you come across any studies? Mike did it.
These medications came out, I think it was in early 2024. So few months later, there was a big cluster of vasculitis in the eye. So people were very afraid. And then there is about 10% risk of conversion of dry AMD into wet AMD. So then you will be stuck with 2 injections. Basically, you are treating dry AMD to prevent the progression of geographic atrophy, and then you are treating with the anti-VEGF treatment. Now, anti-VEGF treatments as a part of CAT trial showed that they increase the risk of geographic atrophy. I mean, maybe aflibercept has less of that because CAT did not include aflibercept patients. So I personally don't use any of the dry AMD treatments because I think the benefit is marginal, in my opinion, and we just use basically these vitamins and sort of other low vision aids. But there are, if you have a fovea threatening geographic atrophy, which you know that, okay, if you don't do it, and if you give good explanation to the patient, you can try in very, very selected group of patients.
Yeah, so these 2 treatments have not been approved in Europe, not just Syfovre or Izervay, and they developed wet AMD. What would you do? And about 10% of people said we'll give them both. We'll give them alternately, which beggars belief, but that's the US system. Thank you.
Thank you, Mr. Shafkat. Next, I would like to call Dr. Abdul Wahab Al-Amri to come to the stage.
Assalamu alaikum. I will give a talk about biosimilar, and this is now the new molecules now arrived, and maybe it will replace the original anti-VEGF for management either AMD or DME. So this one I have talk in the morning, but I will concentrate on this also again. The challenge is that in managing of diabetic macular AMD or DME, and one of the most important is cost burden of medications. So factors that influencing treatment selections when you want to treat any patient that is having AMD or DME, the disease characteristic, either there is a severity of disease or response to previous treatment if you have start with any other medications. Patient-specific factors that adherence to follow-up. This one also is a lot of problems because of the compliance of the patient or age of the patient, and they are not having many comorbidities, so it's very difficult for them to attend the injection on the same times also and follow up. And financial constraints, this is also very, very important, especially in less developed countries or poor countries. But even in my opinion, this one, it can be affect even the countries they are advanced or they are a rich country, even in our region like in the Gulf area. Safety and efficacy, the systemic risk factor, whatever it is, or potential adverse effect. Treatment protocols, we are having inductional phase or maintenance phase or switching to the agents that we are going to. So what are the biosimilar? They are an intravitreal vascular endothelial growth factor. Inhibitors have revolutionized the practicing of the retina in the past decades, but it is associated, is the most important I want to emphasize, with a significant cost both for the patient and healthcare system. So a biosimilar is defined as biologic that is highly similar and has no clinical meaningful difference from the FDA approved biologics. So the product must demonstrate similar pharmacokinetic, pharmacodynamics, safety profile, and immunogenicity and clinical efficacy compared to those reference products. So their development process is longer than that is of generic drugs, but still and more cost effective compared to developing new biologics. Biosimilar are commonly used in many other diseases and not only in ophthalmology. It can be in rheumatology, oncology, and other fields of medicine. And there is many now biosimilar available in the market that are for ophthalmology use, either Lucentis or Eylea. So the concern, what are our concern is biosimilar can be developed faster and are more cost effective than original biologics. They have a potential to reduce the large financial burden of the existing anti-VEGF treatment, improve patient access and increase treatment compliance. And it is the important point that the biosimilar safety and efficacy and immunogenicity are similar to the generic one. This is one of the study about the immunogenicity, efficacy, and after switching from original abstract and published in, I think, 2020 about this one in ophthalmology, Royal College of Ophthalmology, and the result that, however, the initial observational data from this study suggests that switching to biosimilar ranibizumab doesn't have impact on clinical immunogenicity and efficacy in a short term. So in a key summary points, anti-VEGF are highly effective within the retinal disease, but cost can potentially limit the intensity or length of the therapy and thereby provide suboptimal clinical outcome. Biosimilar candidate of ranibizumab and aflibercept are currently in development for the treatment of retinal disease, and some have received regulatory approval that we are going to talk about. So the physiochemical and clinical similarity of biosimilar to its reference is determined by arduous analytic and clinical program, including phase 3 equivalent study where appropriate. Biosimilar may optimize clinical outcome while providing substantial cost saving that can be reinvested into the healthcare system. So what is the scientific evidence available with ranibizumab? I think this one is all we are going to know, all of you, all the study that I think the most anti-VEGF has many study about it is the Lucentis, and so I will not go all through this one. Even the key message that has demonstrated well established efficacy in central retinal utilization among PRN or treat and extend regimen. Personalized regimen also is there. Ranibizumab offers a beneficial outcome across patient population with different ethnicities. So this early also it's showing a different and comparison between different clinical trials, either Rise and Red and others. So this one also is manual. Also, it shows the fewer number of injection required over a time. So there is in case we are using treat and extend regimen. So also it showed in many studies also that ranibizumab provide a good visual outcome even in a patient with poor baseline vision, especially if you remember protocol T comparing in 2 years that the result it becomes similar and no different between Eylea or ranibizumab. So the key take-home message from this one, provide statistically significant and superior visual acuity gains compared to sham or laser. The rapid clinical outcomes of ranibizumab are substantiated up to 5 years and are achieved with substantial reduction in injection frequency over the time. Visual acuity gains are achieved with ranibizumab even in a patient with poor baseline visual acuity. Ranibizumab treat and extend also it's available and it's done. Treat and extend regimen also available and also it's all this one. So this another study shows the efficacy and safety of biosimilars compared with ranibizumab in neovascular age-related macular degeneration, and the result is promising. So I will share with you some cases that we are now switching in our hospital to also to biosimilar. And we are instead of using an expensive drugs, and it's shown that even in developed country and rich country, they are looking for a good product that can replace the generic one with the same efficacy, especially if proved by FDA and so on. This one case of the patient, he is diabetic patient and with both eyes, proliferative diabetic retinopathy and diabetic macular edema. This is OCT pre-injection of Aptera. We call it in our region Aptera or Ravixa. This is the Lucentis one, and we are starting using. And this is the OCT pre-injection also in the Aptera. You can see the photograph and here the OCT itself and the map. And this is both first injection. You can see there is an improvement of that. Both first injection also here again. It shows clearly there is a reduction in central retinal thickness and in the map. So best first injection Aptera in the left eye, that you remember is 2 of them, and the improvement also have achieved even improvement in the visual acuity. Another case, this is 20-year-old and he is diabetic also patient, but this patient came with chronic central serous chorioretinopathy with CMV. So this another way of treating of the patient. So not only diabetic, we are giving in many retinal diseases, and this is OCT pre-injection of Aptera. This also the OCTA. You can see only post first injection of Aptera there is an improvement in the central retinal thickness. Here we can see also the CMV, and this is the both second injection of Aptera, both the third injections. So there is an improvement with this. I'm not telling that this is the good cases, but there is some cases not responding. As we know, it is similar to the Lucentis itself. So this another case here, the patient is mild non-proliferative diabetic retinopathy, left eye macular edema, and you can see this one of the cases, you know, is very difficult sometimes to achieve it even with the good drugs, either Eylea or others. So this both first injection, both second and both third injection, there is a reduction but no complete resolution as usual, because this is one cyst is usually resistant for the medications. So this is the both fourth injection, there is also improvement but not complete, with improvement in the visual outcomes. This is another case here. This is also left eye diffuse diabetic macular edema, and the right eye also, and this is also pre-injection, and this both the third injection. Now I'm showing you after 3 loading dose, so there is a complete between this one and this one. So the another cases here, also a macular edema, OCT, you can see here in both eyes.
Sorry, Dr. Abdul Wahab, we're going over the time limit.
Yeah, I'm just 1 minute, I will just conclude. So there is many injection because I'm trying to show you different diseases, either AMD, DME or RVO, but anyway, we will go to the conclusions. And also this is a study done in UAE about the economic burden, and we get a result. I'm not going through, but it shows that is very important achievement. So the conclusion, biosimilar hold a promise, reducing drugs expenditure and improving access to the high quality biologics. Acceptance and use of biosimilar can increase patient access to biologic therapies, increase number of healthcare providers available to treat patient, shift recommendation of biological therapy earlier in the treatment algorithm guidelines. Lastly, this will improve patient outcome. Thank you very much.
Presentation today will be on AI-enabled diabetic retinopathy screening in Pakistan. I am an MR-VR fellow at the University Hospice Birmingham, and I'm also working as an AI fellow at University of Birmingham. So, isn't this all a bit futuristic? In fact, not. So, a lot of NHS trusts are currently using AI medical devices. They're used in regular clinical workflows, and national and local policies continuing to emphasize AI innovations in NHS services. So, where does all the AI hype come from? So, as we see across the years, different models improve the accuracy, which includes the sensitivity and specificity of how they handle data. And also newer models such as the meta pseudo labels can work with synthetic data, which is basically artificial data. It can work with fragmented data, which is incomplete data. And it can also work with non-labeled data as well. So that's basically the model is training itself. So over the time, as you can see, there is a significant improvement in the accuracy of the models that are being utilized currently in different devices. So what do we mean by AI? And how does AI differentiate itself from DL and machine learning? So DL is basically a subset of artificial intelligence. And as we go deeper into the workings of artificial intelligence, we see that DL is based on a novel kind of architecture, which is the convoluted neural network, which allows a lot of data to be synthesized and to be processed and an output to be given at a very abstract level. So as we go deeper into artificial intelligence, ML and DL, we see that the explainability of the output is decreased, but the reliability and the accuracy of the output is also increased as well. So it becomes increasingly opaque, but the response, it becomes better. So what are the different technical uses of AI that we are currently using? So a lot of you know the generative AIs like the large language models, which include ChatGPT and natural language processing models. Discriminative are the ones that we will focus on the most, which include classification models, which are the ones which can look through an OCT and use an image classifier to tell you if this patient has some degree of glaucoma by looking at the optic nerve, or look at the macula and tell you if this patient has some degree of diabetic retinopathy, and if this patient should be referred to a hospitalized services or to an ophthalmologist, or they can just be observed in your local optician or optom practice. As with any technology that we have, AI-enabled clinical decision can also have bias baked inside of it. So if the representative data that you're using is biased, the algorithm will also be biased. If there's a socioeconomic bias, or if there's an ethnicity bias, if the certain ethnicity is underrepresented, the software or the algorithm will also be biased against that ethnicity. So that is something to be very careful about. Like, AI is not a cure-all, it is not a solution to all our problems. It is just another device, and right now in the UK, it's being used as decision support. So that means that it cannot be unsupervised. It has to be supervised, it has to be used by a clinician, the output has to be studied, and if they're happy with the output, it can be utilized in clinical practice. And the stringency of how these outputs are analyzed and how these devices are categorized are also very stringent. With EU or CE marked devices, if they are giving you something which can change the clinical decision in a clinical treatment pathway, especially like in medical retina or diabetic retinopathy. So this looks at how a CNN basically works. You might have heard the name being dropped, CNN, ALDL. What does it actually mean? How does a computer see what signs and symptoms an eye is displaying? So it's basically just mathematics. What the algorithm does is that it converts the image into mathematical vectors, which are basically mathematical laws and principles. And through every layer of the algorithm, it changes the data set, it changes the image, makes it more abstract. It multiplies it, it converts it, it changes it, it processes it, and eventually it can give you a result based on the data that the image classifier is trained on, that the algorithm is trained on. It can give you an output to tell you if this image has diabetic retinopathy or not, all through changing that initial image into mathematical vectors, processing it, and then comparing it to other data sets that it's been trained on, and then giving you a final result. The whole process can seem very magical, but in fact it is just basic mathematics. So you might be thinking that I've gotten ahead of myself. Pakistan does not yet have a national screening program. How come can we create a program which is AI enabled from the day one? And let me tell you that this is the best time to create a program like this for Pakistan. In fact, we're doing a clinical pilot right now under the auspices of PJO and also Professor Muhammad Moin. Maybe with Sightsaver, we're still filling out the grant application. But just to give you an idea, this is the UK National Diabetic Retinopathy Screening Pathway. So if you see, the most important thing is identifying the cohort of these patients, which is basically building a diabetic register. So if you know where the diabetic patients are, you can definitely bring them in. You can screen those patients, and then you can see if these patients need to go to a doctor or not. So that's very important, is to identify these diabetic patients. Now you might wonder if UK is actually employing AI in its pathways. So England right now is not. They're doing a project which is called ARIUS, which is looking at the feasibility of different vendors to see if they should employ an AI which is supervised or unsupervised. But Scotland right now is using something which is called the autograder. In fact, it is an unsupervised algorithm which they are using since 2018. And right now the published data from the autograder and the Scotland Diabetic Retinopathy Screening Service says that the number of diabetic patients that a doctor or a screener sees has gone down by 40%. So that means that 40% of the patients are seen by the algorithm alone. And if those patients that the algorithm decides are ungradable or has certain features that the machine cannot identify, it flags them to be seen by a human grader. So you can see how much an on-device AI can help decrease the load for a country like Pakistan, where the main problem is basically deployment of human resources and the deployment of screeners that can see these images, extract the necessary data, and then send those patients to hospitalized services. So in a program like this, even if we do a pilot, we can definitely build something in Pakistan, and if we see that it is working, it can definitely be extrapolated to a regional or national level as well. So going by this program in the UK, so what they do is that the patient comes for their images. These images are then viewed by a screener, and depending on what they find on the images, if there's any proliferative diabetic retinopathy, if there's any maculopathy, these patients are then sent to hospitalized services where an ophthalmologist looks at those patients. And if those patients are deemed to be having like background diabetic retinopathy, they can be brought in by annual screening. And in fact, UK is now going to a 2-year screening program as well, where some patients with background diabetic retinopathy can be brought, in fact, after 2 years as well, decreasing the load on the NHS, which is already seeing millions of patients in their diabetic retinopathy screening program. So this is more detail about Scotland's diabetic retinopathy screening program, which uses the autograder. And like we've said, that 40% of these patients are not being seen by a human screener at all. They're being analyzed by the machine, and then these patients are being brought in for further reviews down the line without any human intervention at all. So in Pakistan, if we are to develop a pilot, what are the most important things we're looking for? First of all, we're looking for an AI algorithm which can work with the resource setting of our country. So right now, UK vendors are very expensive. They charge you about £4 to £5 for a scan per patient. CyberSight is a software as a service, which is basically for free. So it both does training and also it's giving out its software, and it is a free to use tool, especially in low resource income countries. They recently published a large trial in Rwanda, which is a similar resource setting to Pakistan, and the major key takeaway from this trial is basically that 30% of the patients, there was a 30% increase in the compliance of the patients, like compared to the arm where the patients were where the images were being taken and the patients were being seen later by a screener, and then the screener gave an output regarding if this patient has diabetic retinopathy or not. Those patients had a 30% less chance of following up in hospitalized services compared to the AI arm where the images were taken. The AI gave an output almost in 1 to 2 minutes regarding the condition of the eye and to see if those patients needed to be seen by a doctor. The compliance in those patients were 30% more in following up with therapy and treatment, and that is a major thing in a low resource income setting like Pakistan as well. So what are the next steps in building a pilot for AI-enabled diabetic retinopathy program? So if you look at the WHO screening guidelines for diabetic retinopathy, the collaboration between ophthalmologists and endocrinologists is the key. WHO says that diabetic retinopathy is being treated by ophthalmologists, but it has to be screened by endocrinologists. Unless a consensus is not built among endocrinologists and ophthalmologists regarding how diabetic retinopathy is to be screened and how to be dealt, it will never be something that is sorted out in Pakistan. So the next challenge is to build a collaboration or a consensus group between endocrinologists and ophthalmologists. Next is the software and the hardware. So CyberSight is basically camera agnostic. It can work with any camera. So any 60-degree fundus camera can be repurposed to run the AI software. You will need somebody to take the images and they can evaluate and just see the images, and then you can run the program. The most important thing, like we've discussed, is identifying the people with diabetes, is building a diabetes register, and then finally is the piloting of an AI-enabled screening. Thank you. So, because we don't have time, we'll just take questions later. Next, I'd like to call Mr. Zulfikar Ali.
Antibodies are the biological products. Whether they are biological products or biosimilar products, both of them carries the risk. And my purpose of presentation today is for the safety of the ophthalmologist and the safety of the patient. So while you are dealing with the monoclonal antibodies, you are probably you are driving the truck full of gasoline. So incidents can happen and they can be very dangerous. Particularly off-label use raises the risk of lawsuits should the patient have a negative outcome. So my objectivity is the concise understanding involved in the various processes intrinsic to the monoclonal antibody production, purification, storage and transportation, and you will see that every process involved in this production of monoclonal antibodies are potentially hazardous. Then is the safe application. I will not comment on this because all of the ophthalmologists are quite sensitive about this thing. Then is the key safeguard step for the practitioner should the adversity occur, and finally awareness about the legal and the regulatory environment in Pakistan while dealing with the biological products. These are the two reports of post-injection Avastin. Both of them are mentioning post-op endophthalmitis or severe eye infection. One occur in our hospital at Ahmedabad and the second occur in Punjab. And this is the report that was presented in the final conclusion of the report in our hospital, where the new time report was presented as an evidence to prove that the burden is on the ophthalmologist. So shortly, what are monoclonal antibodies? Quick review. These are the Y-shaped molecule having light and the heavy chains. Again, they have the variable region, and the variable regions are the antigen binding site, and the constant region or FC region, constant region are responsible for all these immune reactions. One thing another to remember is that these all monoclonal antibodies are the soluble protein. You cannot see it through your naked eye. So larger is the molecular size. This means it is more susceptible to the degradation, which I will tell you. So you can compare the size of these anti-VEGF to the triamcinolone acetonide. We can see triamcinolone acetonide. The molecular weight of triamcinolone acetonide is 0.43 Dalton. This is very small, but if you compare it with Avastin or Fresbispo, they are almost 149 kilodalton. These are the quite larger molecule. There another is fragment antibodies. Fragment antibodies are the portion of whole antibody molecule that retain the ability to bind to the antigen but lack the FC region, and the advantages are, if they lack their molecular weight will definitely decrease. They have improved stability after the production and during transport and storage. There is improved tissue penetration. There is reduced non-specific binding and reduced immunogenicity. So there are various technologies involved in the production of the monoclonal antibodies. We can group them as a upstreaming process and the downstreaming process. In upstreaming process, there is production of monoclonal antibodies, and in a downstreaming, the technology involves the isolation, purification, and of the monoclonal antibody. Regarding the production, there is a hybridoma technology. This is the processes when the antigen is injected into some animals, then these animals produce B cells which produce specific types of the antibodies. Because these cells cannot survive long, these are then fused with a cancer cell. So we called it hybridoma. Remember, it is a cancer cell. The challenge is it is a time consuming, required animal use and may need humanization. Our genetic code is different from the animals. Other is the phage display, or this is also called as recombinant DNA technology. What we do, we take a gene from the synthetic gene library, we inject into the genome of the bacteriophage virus. The bacteriophage virus then infect this bacteria, and these are the basically gram-negative bacteria which produce monoclonal antibodies. You can remember, you can recall from your pathology, these gram-negative bacteria are the bacteria which produce exotoxins. Now, if you incorporate these DNA into these bacteria now producing a beneficial substance, we call it monoclonal antibody. These are again basically the toxins. So again, advantages are avoid animal use, enable engineering of novel fragments like fragment antibodies. They have reduced immunogenicity. They don't need any humanization because the gene that is entered into the bacteria is that of the human, infected human. Challenges are the separation of the viral particles. Bacterial endotoxins are different from the exotoxin. These endotoxins are released when bacteria, there is lysis of the bacterial cell wall. And again, problem related to the bacteriophage viruses. This downstreaming process is the process where antibodies are captured, they are purified, and they are then finally delivered to us in a finished form. So the topmost, the protein A chromatography, by this means you capture 90% of the monoclonal antibodies, but this protein A is a acellular matrix that we obtain from Streptococcus aureus, the notorious one. So you can now think how we are dealing with these things. Then there is ion exchange chromatography. Ion exchange chromatography, it means that the overall, when they subjected to the pH, changes in the pH, they become negatively or positively charged protein. So they move to one or the other side. But again, if there are residual acidic and the basic molecules, they will alter the stability of the drug. Then is the size exclusion chromatography, because you cannot sterilize these biological products or biosimilar product, because both of them are basically the proteins. You cannot sterilize them, you cannot subject them to the UV light, they will disintegrate. So ultimately the process is through the ultra fine filters. The filter that are used in these industries are, they can allow the particle less than 20 nanometer. You can guess that the size of virus is above 20 nanometer and the size of bacteria is above 400 nanometer. This means there is significant safety that is available to us. So the bioreactor, basically all these processes carried down in a bioreactors. In a bioreactor now babies are also born. The bioreactor, you can imagine it as a septic tank containing the products, impurities, unwanted component must be removed, the whole cell protein, whole cell DNA, and particularly if the whole cell DNA is from the oncogene, it is carried into the human, it can become the carcinogenic and leftover material. So just as we read different reports, we must be able to what is required by these lot release certificates. These come in front of our eyes, but we don't know what is important. So there can be impurities that can be a product related, process related, and the clinical critical safety factor that must be in you must see in this certificate analysis. Product, there can be an aggregates. If aggregate means that when these protein aggregate, they become a larger molecule, instead of becoming not only they lose their clinical efficacy, but they become a toxin. So this means we are injecting a toxin into the eye, not knowing what is actually happening. Again, there is a fragment. I will cut short the process related. I have already explained whole cell protein, whole cell DNA, protein A.
Dr. Zulfikar, we're running over time. If you could just.
But just 1 minute, important. This is very safe, important for our safety. Okay? So next is aggregation again. Acha, the most important thing ultimately is the cold chain management. We do believe these are the very good pharmaceutical industry, good pharmaceutical practices, but ultimately from factories they have to come to us. So this is a very sensitive procedure. These must be transported very safely. In fact, when there is in a air cargo, there are portable refrigerator with a real-time temperature monitoring with built-in digital data loggers. They are recording the temperature of the medicine all the time. There should not be no excursion. They should not freeze. Their temperature, unless specified, should fall between less than 0 to 8. Again, they are transported through the refrigerated vehicles from the distribution network to the doctors. These are the guidelines from the DRAP, and it is mentioning that the monitoring sensor should be accurate within plus minus 0.50, and all of us know these medicines are transported to us in a thermos. That is surprising. Again, there are few incidences, Apex incidence and insulin index. Instead of these drug being beneficial, they become toxic to us. This is not new to the other discipline of medicine, but it created a lot of problem for us. So what is important? What to do should the adversity occur? Because it is a very challenging thing, is that a post-op endophthalmitis or it is a adverse drug reaction. You have to differentiate between these two. This is very, very important. So now coming to the whether it is a adverse drug reaction or a bacterial endophthalmitis.
We have three more presentations left.
Okay, sorry. I think I was in the last.
We're done with the time. I'm really sorry.
Sorry.
Wrap it up.
Bas I wrap it up. You have to differentiate because if it is a drug adverse reaction, it must be very, very quick. The moment you inject, within a couple of, there will be severe pain. But since if it is a bacterial endophthalmitis, it will take certain time for the bacteria to become significant and then to produce their clinical effect. Another key difference is the cluster of cases. You use the word cluster endophthalmitis. In cluster endophthalmitis, we should not use the word cluster endophthalmitis. We must use the term and adverse drug reaction, because if you use the term cluster endophthalmitis, the fall will be on the ophthalmologist. He has to bear the consequences. But if you label it as a adverse drug reaction, and which is the fact, now you can realize. So the problem will be pharmacist. This is not a problem in the Western world, but here it is really a problem. So another thing is, you must know, whenever you take there is GTI number, Global Trade Identification number. This is the Global Trade Identification, it is a unique number. So whenever you are requesting for this, always ask from the procure the drug from the authorized distributor in your local distribution network. Always ask for the warranty and invoice. This is the legal requirement. Without invoice and warranty, if he delivered it is committing a crime. And also additionally, I should request always ask him to mention GTI number on that invoice and warranty. That will save you. This is my popular picture when I was kept prison for 3 days. So that is important. So इसलिए मैंने शुरू में आप लोगों को आपको टॉपिक्स बताए हैं कि दोनों में आपको लिखा क्या गया है. लिखा आपको ये किया है पोस्ट ऑफ एंडोफ्थल्माइटिस और सेवियर आई इन्फेक्शन. क्यों नहीं लिखा गया कि दैट इज एन एडवर्स ड्रग रिएक्शन? आपकी सिनेरियो चेंज होता है, आपकी चीजें चेंज हो जाती है. मैं अभी तक 2 साल से कोर्ट केसेस भुगत रहा हूं और ये ओएसपी के लेवल पर होना चाहिए. और मैं कोर कहता हूं कि जब भी ये चीजें होती हैं तो ओएसपी को अपना रोल प्ले करना चाहिए. कोई एक तो होना चाहिए. एक हमारे साथ मसला होता है, जब ऐसा कोई इंसिडेंस होता है हम इसको रिपोर्ट नहीं करते हैं. जब भी ऐसा इंसिडेंस हो उसको फौरन रिपोर्ट किया करें, या ओएसपी का रेलेवेंट चैप्टर है उस पर आप ये रिपोर्ट करें कि ये इंसिडेंस हुआ है, ताकि इससे पहले कि मीडिया का वो मसला बने आप उसको कवर कर सके. और दूसरी बात है इसमें थोड़ी सी मैनेजमेंट में है, थोड़ा सा कंट्रोवर्शियल हो जाएगा।
Dr. Zulfikar.
थैंक यू। चलिए इसमें बाद में क्वेश्चन
So we will take questions later. Uh, Next, I would like to call Haji Ismail Siddiq.
I will just go through two of my cases. We are fellow at AKU. So first of my cases was dealt under the supervision of Dr. Iman Siddiqui, a real peripheral lesion of retina. So this is my disclosure statement. I have nothing to declare. So he was a 58-year-old male patient present in our eye clinic with a complaint of right eye floaters, which are present for around 10 days. He has a past ocular history of right eye buccal surgery, which was done way back in 2006. Other than that, nothing was significant. Coming to the examination, NTS examination was unremarkable. You see this right optos. Here we can appreciate that there is a tumor with this. This feeder vessel is along with this, and here we can appreciate there are laser marks along with that. So this was a red lesion which was around 1.5 by 1.5 by diameters, and along with that feeder vessel was also seen, and non-pigmented was the lesion. So the other optos came out to be normal. So fundus autofluorescence along with the fluorescein angiography was done, which showed that in late phases we can see that there are hyperfluorescence of the lesion as well. So the main differentials which came in our mind was that of retinal hemangioblastoma. How can we differentiate this from that? Is that there is a well-defined characteristic feeder vessel is seen in retinal hemangioblastoma, whereas in VPTF, vasoproliferative tumor of the fundus, there is usually not well-defined. And in the late phases also, on FFA we see diffuse leakage if the case is of VPTF, and if we are suspecting hemangioblastoma, there would be late leakage around the feeder vessels, and along with that there would be macular involvement in VPTF tumors. So we managed the patient where we did 3 laser sessions. Along with that, intraretinal AntiVEGF was also given. Patient was followed up. The intraretinal AntiVEGF was repeated. So gradually the patient improved, the feeder vessel regressed. So our working diagnosis was that of VPTF secondary to the buccal, which was done. So it's a rare tumor, it's benign, vascular, and it's usually present in the 3rd to 4th decade, affecting both the genders. So usually it's a pre-retinal fibrotic mass, which is a disorganized vasculature, and peripheral vascular mass is seen with the surrounding exudation, so it mimics that of a cord disease. And usually the primary tumors are solitary, while the secondary, they are usually more common than the primary one, and they are usually bilateral as well. And histologically, when you see they are composed of glial cells, and network of fine capillaries are also seen. So ocular manifestation, as in our case, there was a globular yellowish mass seen. Along with that, the surrounding exudation and macular fibrosis can also be seen. This is more important. Feeder vessels, normal or slightly enlarged caliber vessels can be seen entering the posterior aspect of the tumor. Usually it's lack the marked dilation and tortuosity which is present in other tumors. So these are the characteristic features, peripheral location, and along with that education. So it's usually located in the inferior temporal quadrant of the retina, and usually patient present with the vision loss, floaters. So on B scan, what we appreciate, there is a solid lesion. Along with that, there is no choroidal excavation, and the internal reflectivity is usually increased as well. So how do you manage these cases? Usually when there's cause of vision loss, then we proceed with the treatment. We have multiple options. As in our cases, we can go with the anti-VEGF, or we can also manage with the lasers as well. So these are the other multiple options available. So VR surgery is only indicated when there is associated retinal attachment associated with that as well. So what are the other complications we can appreciate? If the patient present with VPTF, that can also cause epiretinal membranes, and along with that macular edema can be seen. It can ultimately lead to scarring, and retinal hemorrhages are also part of the complications. Histopathologically, as we said, that's composed of the glial cell and the vascular elements. is a misnomer because it's usually display a paucity of the microvessels, and proliferating fibrous astrocytes are the main component of that. So, it should be ideally cause a reactive retinal astrocytic tumor rather than VPTF. So closely monitoring the cases, as there is a chance to reoccur. There is the chance that it may ultimately lead into neovascular glaucoma and can also cause recombinogenic retinal detachment. So the some of the only was after the literature review, I found only a few of the cases were reported which led to scleral buccal. So I'm just going ahead. Those secondary visual proliferative tumors are more frequently observed than the primary tumors, and the peripheral retinal lesions simulating the retinal tumors involve these list of tumors. So just thanks, end with this case and just shifting out to another case, as we are just running short of time. Yes, sir, yes. Sir, वो second case. Yes, yes. Thank you.
Last presenter, Dr. Hinana was
ophthalmologist at the leading hospitals at Karachi. Topic for presentation for today is anti-VEGF use in PDR in fractional retinal detachment with and without macular edema. So we all are familiar with the mode of action of anti-VEGF. It is a common treatment in PDR with and without diabetic macular edema. Anti-VEGF reduces both neovascularization and macular edema. So after several clinical trials, the FDA has approved ranibizumab and aflibercept for treatment of PDR without diabetic macular edema, but without specifying the level of diabetic retinopathy severity. According to the protocol S, ranibizumab is non-inferior to PRP at 2 and 5 years for PDR treatment. It has lower rates of diabetic macular edema development and has less visual field loss that are usually associated with PRP. As the Clarity study shows that aflibercept is far superior to PRP at 1 year for PDR regression. PRIDE study demonstrated that ranibizumab has effective regression of neovascularization and has better visual acuity. So the question arises, what should be the mode of treatment? PDR without macular edema, specifically in the cases when there is no macular edema associated in PDR cases. Should we go for anti-VEGF as monotherapy, or should we go in combination with PRP? What should be the dosing schedule in both the scenarios? What should be the follow-up regimen, and what's the end point? So there are many pros and cons associated with anti-VEGF. It has effective neovascularization regression. It can prevent the diabetic macular edema prevention, and it has good roles in visual outcomes. And the far most better thing is it has the very good effect of preserving the night and peripheral vision, which is associated with PRP. But it was also associated with many cons. It is associated with recurrence risk, advancement of PDR, and also associated with the famous Crunch syndrome. And in the part of the world where we practice is the cost that really matters in our patients. We should always consider the serious side effects of anti-VEGF. So treatment in PDR without macular edema, major ophthalmology societies, especially the American Academy of Ophthalmology, still consider PRP as first line of treatment for PDR without diabetic macular edema, but recognize anti-VEGF as an alternative in selected cases. It is preferred in younger patients with low compliance risks and good healthcare access. So what are the treatment challenges? Anti-VEGF regression is temporary and requires sustained treatment. If the patient misses the injection, it is associated with rapid neovascularization, rebound, and potentially worse outcomes than if PRP had been performed initially. So what are the treatment protocols with PDR with macular edema? There are multiple. One of them is monotherapy, monthly intravitreal injections until PDR regression and associated with diabetic macular edema regression. The other is the standard regimen associated with the loading phase and the maintenance phase. We should also consider adjunctive PRP after diabetic macular edema resolution. We can also use anti-VEGF as an adjunct in the treatment of tractional retinal detachment. There are multiple uses. The pre-operative use helps to regress the neovascularization, leading to less intraoperative bleeding and lesser iatrogenic retinal tears. Intraoperatively, it helps control bleeding, improve visualization during the procedure. And post-operatively, it manages residual or recurrent neovascularization. We should always consider to monitor the potential complications like TRD progression or macular pucker associated with anti-VEGF. What is the ideal window that we have to give anti-VEGF before proceeding for the vitrectomy in cases of TRD? So after several studies, the ideal time period is between 3 to 7 days. Prior to surgery, it gives the best results. It allows the effective regression of neovascularization and it minimizes the risk of crunch syndrome. Combination therapy, that is combining the anti-VEGF with PRP, it is associated with rapid response of anti-VEGF with the long-term durability of PRP. It reduces the treatment burden compared to the anti-VEGF monotherapy. That is really important in the part of world that we practice. Ideal candidates for combination therapy are those who have high-risk PDR with and without diabetic macular edema, dense pre-retinal hemorrhage, poor compliance with frequent injections, residual neovascularization after monotherapy of intravitreal. On the daily basis, we see multiple patients. Let's go through broadly. There is one scenario, you're sitting in your clinic and you see a patient with PDR having NVD and neovascularization elsewhere. But the good thing is that there is no tractional element. If there is good compliance and regular follow-up, what would be the treatment regimen? You can plan intravitreal anti-VEGF monotherapy in such cases. Another patient but with much severity, PDR with center involving diabetic macular edema. Same, the patient has good compliance, you can consider anti-VEGF monotherapy, but you should differ if the patient is non-compliant and go for PRP rather than anti-VEGF in such scenario. Another scenario that we see on daily basis is PDR with traction not involving the fovea yet. It can involve the fovea in like 1 year and 2 years. As the time passes, the risk increases, but PRP can be completed avoiding 1 disc diameter area from the TRD. If this condition is associated with diabetic macular edema, initial treatment with intravitreal anti-VEGF can be started and PRP added at follow-up visits. Patients with PDR treated with PRP first, then subsequent anti-VEGF injections are more likely to go vitrectomy for vitreous hemorrhage and TRD compared with MASH patients treated with anti-VEGF agents first and then PRP. Another scenario that we see usually is active PDR, although the patient has already underwent comprehensive PRP, maybe because of long-term diabetes or poor compliance, the patient still has, you can see active proliferation and associated hemorrhages even after the comprehensive PRP. In the absence of traction, intravitreal anti-VEGF would be a viable tool in this patient. Another patient who has PDR with neovascularization at iris, a combination therapy is really helpful in this scenario. Anti-VEGF gives added advantage when PRP is not possible due to poor view. Ensure the IOP is medically controlled before giving the intravitreal anti-VEGFs. So what are the key takeaway? Anti-VEGF is a powerful tool but still a not replacement of PRP, especially in our country where compliance is a major issue. Combination therapy may provide optimal outcomes, like we can take the benefits of intravitreal anti-VEGF and avoiding the PRP side effects and then taking help from the PRP also. The tailored treatment approaches can address individual patient needs. We cannot put all the patients in one box. We have to treat them according to their own disease manifesting stage. Thank you.
I think that's all for this session. The next session is already due to start.